So we talked about nowadays with a lot of antiemetics that incidence of nausea really should be minimal. But if you look at studies, surveys, it still happens commonly. It's estimated on average 30% of your patients will develop post-op nausea and vomiting. These are all comers. And in high-risk patients, even up to 80%. So it's extremely high. And we know that if you have a patient who unfortunately following ambulatory surgery because of nausea and vomiting cannot be discharged, if they stay in the hospital, overnight hospital cost is extremely high. And that in itself is well worth to think about, can we better provide prophylactic antiemetics to prevent patients from having to stay back in the hospital. As I mentioned earlier, patients always tell us that nausea and vomiting is something that they really hate to experience after surgery, even more than pain, as this survey demonstrated that PONV is the most common reason for poor patient satisfaction. 50% of the patients that said that nausea and vomiting is far worse compared to pain, about 27%. Now, those of you who put patients on PCA following surgery and you see them post-operatively, you get a call from the patients that the patient tells you that they have 10 out of 10 of pain. And the patient, when you go and see her, she has a PCA button in her hand, and you looked at the PCA machine. The last time the patient pressed the button was about half an hour ago. And you said to the patient, well, if you're complaining of pain, there is the pain button. When you press the button, you get a dose of painkillers. Why don't you press the button? And now the patient begin to tell you that the reason why this patient did not press the button. So we were interested in this question because patients constantly trading off between giving themselves painkillers at the same time titrating their pain, right? And when we ask patients, why is that you don't press the pain button until the pain goes down to 0? And you almost never see patient on PCA tell you pain is 0. And it's because there are potential side effects when they press that pain PCA button. Whether you use fentanyl, hydromorphone, morphine. And this study shows that patients would rather have some pain, but they hate to have the side effects as a result of the drugs, the opioids, when they press the button. So when we give them a scenario between whether you would want to have good pain relief that come with it moderate vomiting because of the side effects of the drugs, or just fair pain relief, but with no side effects. Overwhelming majority of patients say, I would rather tolerate some pain, but I hate to have the side effects. Same goes with constipation or itchiness. So patients constantly trading off between efficacy of analgesia at the same time of side effects profile. And that's why PCA patients almost never get down to pain score of 0. It's always between 3 and 4. They say, I can live with that, but I don't like some of these side effects when I press the button. Post-op nausea and vomiting also, because of opioids, we see a lot of post-op nausea and vomiting. Now, if you have an opioid-sparing strategy using multimodal analgesia, your PONV score typically reduces. But again, this study shows that you still see some post-op nausea and vomiting. So it's not all due to opioids. And there are some other factors that can also promote PONV as well. Now, sometimes we wonder, if I were to have a great antiemetics, right? The antiemetics that I'll give you would prevent nausea and vomiting. Would our patient pay for it? What is the willingness to pay for an effective antiemetics? So we did a study a number of years ago asking patient who had surgery in a PACU and asked them, how much would you be willing to pay for an effective antiemetics? And interestingly, we found that those patients, all comers with no nausea and vomiting, they said, I would pay about $55 or so on average for an effective antiemetics. And those patients who had nausea went up. I'm willing to pay over $70 if you can give me a dose of antiemetics that would treat my nausea. Those who have vomited went up even higher. So that shows that it is something that a patient really wants to avoid and also even willing to pay for it. And this willingness to pay study is very commonly done in other industries, but somehow in healthcare, it almost seems like taboo when you mention dollars and cents. But if you ask patients, they are willing to pay for that if there's an effective drug. We know that although rare, post-op nausea and vomiting can lead to even more severe problems. And these are some of the reports that we see in the literature on the consequences of untreated or severe nausea and vomiting. Electrolyte imbalance, because they keep throwing up, can potentially hurt their surgery, especially plastic surgery. If you have a facelift, the surgeon just done his wonderful job, and then you begin to retch in the PACU. If you are the anesthesiologist, I don't think the surgeon likes you that much. Respiratory complication, aspirations. So there are complications potentially as a result of nausea and vomiting or retching.